Hmm.
انا بلغت الناس على الواتساب ان احنا هنبدأ خلاص.
تمام. That's fine. Sorry for this technical error. I hope that you enjoyed the Eid al-Fitr for those who are fasting, and I hope for all people good days, especially in this Corona era. And I hope that this will be over, inshallah, soon, and all of you come back to your full active life. And try to fix as much as you can from acetabular fractures you meet. Just to link the what we have said before, we will discuss in this lecture the third part of the series of acetabular fractures from A to Z or A to Z. And now, in this case, it's the fun part because we'll discuss some cases and try to highlight the tips and tricks of fixation of acetabular fractures. We couldn't say that this is easily manageable through online session. The best setting is in the wet lab for the approaches and in the dry bone in the workshops. Try to master these techniques, but bit by bit, by chunking. Also, this lecture is not meant for exhausting all what's read or what's written in the textbooks in fixation of acetabular fractures, because if you want to have a good review for this, you can go through many books. One of the best is resources is the AO surgery reference, and I think all of you are familiar with. So I recommend for any case you face, even if you are assisting in the case, not the primary surgeon, especially if you don't have much experience, to reread every time you reread the approach and you read the fixation strategy. And if you keep doing this for all your all cases, not especially acetabular cases, every time you read it, you just will have a more in-depth knowledge, and you will develop what I call the third dimension of knowledge, which is how you be
دكتور عبد الله، دكتور عبد الله،
fracture.
دكتور عبد الله معلش اخر دقيقه بالظبط او 30 ثانيه كان الصوت مقطع عند حضرتك.
Okay, we will go again and revise these 6 steps for good management of acetabular fractures. We already did the classification, and I hope you enjoyed it. And we already did the 2 parts of definition of the articular surface injury and identification of the indications for surgical or non-surgical treatment in the decision-making lecture. And also we touched the plan, as we will clarify in a moment. We touched the approach part of the plan, and now our work is how to execute our plan. Okay? And we will have a very small hint about the surgical intraoperative complications, which should be in the ideal world, should be avoidable as much as you can. When you put a plan for surgical fixation of any fracture, always you talk about these 4 parts or 4 points. First is the approach, and then after you had done your approach in a tidy manner, you did it without soft tissue massive trauma, so you did it in a good way, and you avoided retraction of the nerves, retraction on the vessels. You know what is the limitation of your approach, how can you judge the reduction through this approach. Some part of the approach you can directly visualize the fracture, and a part you just allowed to use your finger to touch the fracture ends and to see whether they are reduced or not. So you should know the limitation of your approach and should do it well, as we discussed before. Then you should have a moment, maybe 1 or 2 minutes, before you touch anything to identify the zone of injury and to compare this zone of injury to what you have seen in the X-ray and in the CT. And here, in the identification of the zone of injury, comes the role of the 3D CT reconstruction. As we said before, in the 3D CT is not as much, our philosophy in Alexandria at least, is not as much as important for classification. Also, it is not the ideal tool for decision making before you need to see by your microscope, which is the axial cuts of the CT. But indeed, it is very useful in planning of your surgery, in planning of the position of the screws, in planning of the reduction, in counting the important fracture fragments, in trying to order the sequence of reduction, as we'll see in a moment. Then you go for reduction and fixation. We saw this slide before, but this just for confirmation and emphasizing that it's very important to classify the fracture, because when you have a good classification of the fracture, you will solve the approach straight away in at least 6 fracture types. So there are 3 pure posterior fractures. They are the posterior wall, posterior column, and posterior wall and column. And there are 3 pure anterior fractures, which are the anterior wall, anterior column, and anterior column posterior transverse. All of these fractures have either one approach, which could be the posterior in the first 3 and anterior in the second 3 fractures. Here is the dilemma in the remaining 4 fractures, which constitute also dilemma in diagnosis, almost all of them, except for the transverse. But at least you should know that the both column fractures, associated both column fractures, is almost an anterior approach, and in T-shaped fracture and transverse posterior walls, almost posterior approach. We went through the cochlear approach, and also went through the ilioinguinal and the stoppa approach. And I need, if you need to elaborate more in surgical dislocation, please leave your comments or just send a notification message or email for the organizers, including Dr. Muhammad Atif. And inshallah, we are ready to give a separate lecture about surgical hip dislocation, if you like it, okay? So the second part of the plan is to identify the zone of injury. You start to identify where is the stable fragment. These fragments will hold your screws of the buttress plates. And then you start to count the fracture fragment or fragments, okay? So depending on the mechanism of injury and the position of the lower limb during the injury and the direction of the trauma vector, you will have variety of fractures. So, for example, a posterior fracture is not one entity, even if it is a simple fragment. It is not easy to unify all posterior wall fractures in one pattern. This is totally different from what can you see in other articular fractures. At least in other articular fractures, you see more or less stable pattern or the same pattern. But in the acetabular fractures, it's very important to identify the location and the size of the fragments. Whether this fragment is belonging to the column or the wall, it's very, very important, because when we see the ordering of your fixation, you will see why this is very important. So keep in mind this point until we go through the presentation. Again, the displacement and of the fragment, and whether the fragment is displaced, how much is displaced, and the amount of soft tissue stripping you need to reposition this fragment, and how much this displacement affected the underlying the underlying soft tissues. Okay. One most important factor in reduction, which is a part of displacement, but I wrote it here separately because it is very, very important, very critical, is the rotation of the fragments. Because mostly in acetabular fractures, the malreduction is in the rotation, and because you have this flat bone of the pelvis, so you have many bony inequalities, so you will not be able to identify the rotation as much as you can. Anonymous attendee. Okay, I will keep this for inshallah, I will keep this for the end of the session. He is asking why both columns fractures always anterior approach. I didn't say it's always anterior approach, it's almost always anterior approach. We can start posterior in some limited indications, and we will see it inshallah. So again, because the pelvic bone are not symmetrical bone, it's not uniform, so you need to assess the rotation carefully. Okay, and what will make your life difficult is the comminution of the fragments. So even if you have a cortical comminution, small fragment comminuted, it's very important because it will lead you to the whole picture, just like the puzzle. So you need every small fragment, because this fragment could not be very important in itself because it does not hold the articular surface, but it's very important because you need it to see the whole puzzle solved, so you judge your reduction as accurate as you can, because you know that the articular surface of the acetabulum is only 3 millimeters in thickness, and any small displacement of a critical fragment will show in itself in articular stepping off, and this articular stepping off will cause early osteoarthritis, especially if it is a step, not a gap. So again, comminution and identification of comminuted fragments is very important to solve the whole puzzle. Sometimes you need to go inside the hip joint to see the femoral head lesion, to retrieve loose intra-articular fragments, and to manage what's called marginal impaction, which is the MI of the hip joint, like the myocardial infarction. If you have a marginal impaction and you didn't reduce it, this hip joint will die. Last but not least, the soft tissue is a part of the zone of injury, so you should identify labral tears. Be prepared by some ankles if you need to relocate and fix the labral tears. Also, the capsular tears should be identified, because if you want to extend the incision of the capsule to see, you should take in consideration the traumatic tear, so you don't do double trauma to the capsule, but just extend the traumatic tear and try as much as you can to preserve the blood supply to the femoral head. I think here is the blood supply of the femoral head. Before you go to fixation, you should be familiar with the set for acetabular reduction and fixation. These are the basic sets. We have also in Alexandria the co-linear clamp. Thanks again for Mahmoud Hashish, which is not here in the picture, but at least you can't go through any case if you don't have this set. So just it is not this clamp only, the reduction clamp, which is the classic one, but you have these clamps, which is called the Farabov Jungruth, reduction clamps. You have the meta clamps, okay, and you have the asymmetric clamps of Mayo clamp, okay. So all of these clamps are very important. Farabov clamp, and we don't have the Jungruth clamp here. It's not very seen here from this profile. But all these clamps are very important. One of the most important tools is the T-handle and the pole spike. These are your friends in the reduction of the acetabular fractures. So these are the Meta clamps, the Farabov again clamps, and the Mayo clamp. Let's start with this case. First of all, the classification. Here is the iliopectineal line intact. So this is a pure posterior injury. It's either posterior wall, column, or wall and column. If we go through the ilioischial line in the non-injured side, you see it's very clear here, continuous here above until the greater sciatic notch. But here, this line is intact distally, proximally, and it's missing here. So we have something in the posterior column. It's evident here in the lateral edge of the ischia that the posterior wall line is not continuous, but the anterior wall line is continuous. But we don't need these lines, we just need these two lines as we said in our algorithm. So it is either a posterior wall or extended posterior wall to the posterior part of the greater sciatic notch, is called the retroacetabular surface, or it could be a posterior wall and column, but because the column is not separated distally, we can't say it is a posterior column. It's either a posterior wall or what's called extended posterior wall. So this is very useful diagnosis in the X-ray. And why I say it is very important to know the X-ray, because if you see this X-ray and you don't know whether there is a fracture posterior to the hip joint or not, you'll not be able inside the surgery to know whether you reduced this fracture right or not, because you don't have CT inside the operative theater. Here is the CT scan. This is our microscope to identify the injury, and this is our maquette to plan for surgery. And nowadays, we do, myself and Mahmoud, we do what's called 3D printing model to allow us to plan our surgery and even to do the surgery in vitro before you go to the patient truly inside the surgery, and then you can pre-contour your plates before you go surgery to save time in the surgery. Nevertheless, this is your microscope again for identification of injury, and we'll do it together now. And this is your maquette for planning of your surgery. If you see this incomplete fracture, one of the important advantages of the 3D CT is that you allow you to see some incomplete fractures. So it is a transitional fracture between a column and a wall and a pure wall. But at least we have here very clearly comminution. We have this important fragment of the greater sciatic notch. If we go to the CT, which is the axial CT, again, your microscope, this is the stable fragment. So if you follow this CT from the sacroiliac joint, but for the sake of time, we didn't get it, you will see it's stable, stable, stable. So the anterior column is attached well to the sciatic buttress. There is no anterior column fracture. Here is the start of fracture of the posterior column. So this is the cortical fracture of the posterior column. Here is an impacted articular fragment. Here is a second fragment, which is cortical wall fragment. And here is the start of plastic deformation of the medial wall, this side, anteriorly. So this plastic deformation of the medial wall, but there is no induction of the articular surface anteromedially. So this fragment is not that important because it is not attached to a significant articular fragment, and it's just important to reposition it to know the good rotation of the column. Okay, and here you have an intra-articular fragment, small intra-articular fragment. Are you following me?
حضرتك متابعين.
Okay. This is the most important view in 3D CT because it is a posterior view, so it's just like you see it from the inside. Anybody can tell me which would be this approach? The approach for this case. I need body to write it here. Answer this in the answer question and answer part. What is the approach? Please write the approach you know. Posterior approach. Yes, that's it. Anybody has another idea, another opinion? So it's very important to know how to reposition all these fragments because again, the pelvic bone is uneven, flat bone. So you should follow every elevation and depression in the bone until you be sure that the fragments are well positioned. Okay. Okay. So let's start. This is the most important slide in our presentation. This is after about 15 years in acetabular fracture fixation. I had this fixed philosophy in all of my cases. So first, I repositioned the femoral head in its proper location. I did not accept any subluxation of the femoral head. And I spend my time, take my this femoral head from proper reduction. So if there is interarticular fragment or hello.
والله معلش هو بس في يعني بس الفيمورال هيد بس من الأول معلش.
Again, these steps are very important and fixed in all my cases, almost fixed. Okay. Number one is that I reposition the femoral head in its proper position and see what is preventing the femoral head to be reduced in its proper position. So if you have, for example, an old fracture, challenging fracture, you should see where is the femoral head. If the femoral head is following the posterior column, even if the fracture is both columns fracture and the classic is to start anteriorly, it is one of the limited indications that you will go through the posterior approach first to make sure that you reposition the femoral head in its proper position. And here's the essence of whether to use traction table or apply manual traction through the assistant and your instruments inside the surgery. So there are two philosophies. Some of the American guys following Joel Matta do most of these fractures on the traction table to make sure that the femoral head has been retrieved away from its central position or from its posterior position to its anatomical position, and then rebuild the acetabulum as using the femoral head as a template. Or you know that during surgery we need some strong assistant to and steady to make life easy for you to reduce the femoral head. And it comes that the assistant want to see, and it's not even easy to see and apply effective traction. So one who's doing the traction, he should know that he's doing a very great job, but he can't see at the moment of reducing the fracture. Second, when you reposition the femoral head in its place, and you see if there is intra-articular fragments, you retrieve it. You use the femoral head as a template for reduction after reducing this femoral head. Either you see the reduction, the articular reduction through the wall fragment, so you elevate the wall fragment and see the reduction of the main articular surface of the acetabulum. Or you, in some cases, you may go through capsulotomy at the side of the acetabulum, not to injure the femoral vessels. I mean the ascending branch of lateral femoral, medial femoral circumflex, ascending branch of medial femoral circumflex artery that supply with femoral head. Or in most of the cases, when you do an extra articular approach, which are most of the anterior approaches are extra articular approaches, you will rely on the image intensifier to see that the femoral head is well positioned and the fracture is reduced. What is the reduction sequence? First of all, you should reduce the column first and then fix the column, which are the supporting bone for the articular surface. And here is the difference between acetabular fracture and any interarticular fracture. In any interarticular fracture, the usual sequence is to reduce the articular surface first, and then to reduce the articular block to the supporting metaphysis. In the acetabular fracture, you need to build the outer shell first, and then use this outer shell and the femoral head stable within this shell to rebuild the small intra-articular loose fragments or impacted fragments, while the cortical skeleton of the pelvis is reduced and maintained. So first, you reduce the column, and then you will reduce the wall. You reduce the column and fix it, ideally absolute stability by intrafragmentary screw or compression plate, and then you go to through the wall. If you have the two columns, how to choose which column to reduce first? You start, the usual rule is to start from proximal to distal in the direction of the joint. And here is why in both columns, fresh fractures, the anterior column is higher, as you all know, it's reaching the iliac crest. This is why we start anteriorly most of the cases, to reduce the anterior column to the sciatic buttress and then to follow with the posterior column. In the stop approach, there is some modification of this classic rule, and we'll go through this modification, inshallah, in this lecture after a while. Then, when you had your skeleton, the column are reduced and fixed, you go and to see inside the joint again to make sure that the small articular fragments, if needed to be repositioned and have an independent fixation for these fragments by small or mini fragment screw or serrated wire, whatever, what's called two-level reconstruction. You go through this. And then you close the shell, which are the walls, and fix them, ideally, absolutely, if there are simple fractures, or by spring plates, which are the anti-glide plates for the posterior walls, as we'll see in a moment. If the fragments are comminuted, so you can't achieve absolute stability. And then you bridge the whole construct by a large buttress plate. In the anterior column, this plate is spanning all the distance from the iliac wing, from the sciatic buttress up to the symphysis pubis, and the posterior column spanning the whole retroacetabular surface to the ilium above the greater sciatic notch and distally to the ischium. And the last tip, I always reduce, as you see, from proximal to distal, as we said, but in fixing the buttress plate, I prefer to put the distal screw first to avoid what's called the helicopter effect. So you put the first screw in the posterior column in the ischial tuberosity. You don't tighten it until you reposition the plate proximally, and then you tighten it as usual. Also, in the anterior column fractures, I put the first screw in the symphysis pubis, or the body of the pubis, and then I reposition again the proximal plate in the iliac wing or iliac fossa. The fixation devices used for acetabular fractures could be divided into buttress plates. Sometimes you can use these buttress plates to compress the fracture. These are the posterior column or wall plates, the reconstruction plates. For the wall fractures, if you underbend the plate so the edges are higher than the center, this will allow you to compress the central part of the fracture, which is the wall. In transverse fracture, if you overbend so the center is higher than the periphery, this will allow you to lock the anterior column fracture part of the transverse fracture. The classic buttress plates are again the posterior plates, wall or column, the pelvic brim plates, and the iliac wing plates. And lastly, the infrapectineal plate, which is allowing direct buttressing of the medial side of the acetabulum through the stoppa window, which is called also the quadrilateral plate. All plates could be fixed in one side and not fixed in the other side as anti-glide. The most famous examples are the posterior wall spring plates and the medial wall spring plates. So you can bend a plate in L-shaped, and you put the screws in the iliac fossa and leave the free end buttressing the medial side. In the spring plates, the posterior wall will see amount how to use it. Also, there is what's called short segment fixation. This was published by Cairo University Group, that you can fix the anterior column through the lateral window of the ilioinguinal approach, and you extend your plate until the iliopectineal imminence without putting plates distally to the lower part of the anterior column. And the third example or third part of the plates is the specialized plates. So you have a plate which is pre-contoured, pre-made, that is omega plates or striker plates, that you do just small modification inside the surgery, but these plates will hold both of the medial side of the acetabulum and the iliac fossa in one plate. Okay. Yes, Muhammad, I repeat it in the coming slide. For the screws that you need for intra-articular interfragmentary compression, so when you need absolute stability, you either use these buttress plates as a compression plates, So sometimes we use small set dynamic compression plates, DCB, in the column, posterior column, or a part of the anterior column to compress the fracture before you put the buttress plate, which is the reconstruction plate. This is one way of achieving absolute stability. The other way is that you can put the screws. The screws are the most useful and most important tool in fixation of acetabular fracture, because it is not cumbersome. You don't put much metal, and allow you with good compression and allow you for absolute stability. Either you put it in the open classic method, so you see the screw while you're doing it, in you fix the posterior wall or column. There is safe trajectories that you should know when to, where to start, where to end, what is your direction, to avoid putting the screw intra-articular or through the fracture, or going beyond the bone to dangerous soft tissue. Again, you can put interfragmentary screw for the anterior wall or column. What is mostly used is what's called percutaneous screw. In percutaneous screws, in very limited indications, you can do the case percutaneous without opening. And I think we did the last case like this because we had some problem in the skin distally. Okay. But عاطف سامعني الصوت؟
سامع حضرتك كويس.
Good sound. Okay. But in the most situations, you need these percutaneous screws even if you are doing open surgery. Why? Because you don't control the this other side of the acetabulum except by the image. Although you are opening, for example, posterior approach, and you need to fix the anterior column. So you put the reduction clamp on the accessible part of the anterior column, and then you judge your reduction by the image. And then you put the screw totally dependent on the image. And the essence of all of these screws is that they are intramedullary screws. So if you know what is the cylinder you are putting in your screw, and you hit the right entry point of this cylinder, and you go through the medulla, then you will achieve the longest screw you want to achieve in the X-ray, and it will be very safe. Again, if you need a lecture about percutaneous fixation of pelvic and acetabular surgery, we have one lecture ready for you. If you want it, we can put it in our plan, inshallah. The most used screws from this side is the anterior column screw from the posterior approach, or the posterior column screw from the anterior approach. Either you put it in an antegrade or a retrograde manner. And usually in the anterior column screw, put it from the ilium to the pubis. So this is called an antegrade because it is from proximal to distal. But if you put it from the pubis to the ilium, it's called retrograde. Again, if you put it from the ilium to the ischium, it's antegrade. If you put it from the ischium to the ilium, it's called retrograde. So it's logic. If you open posterior approach, you have the ilium. So you go from the ilium to the pubis. It's logic to have it antegrade. Also in the anterior approach, you open the iliac fossa from anterior. So it is very easy to recognize that the screw is an antegrade screw. We have what's called supraacetabular screw and magic screw. Both of these screws are for the dome of the acetabulum. One of these screws starts from the iliac fossa anteriorly and hit the medial wall of the acetabulum. And the magic screw, if you hear about it before, it starts from the outer surface of the iliac fossa and hit the medial wall again of the acetabulum. The lateral compression type 2 screw are the fixation device for iliac wing fractures. So you start from the anterior inferior iliac spine up to the posterior superior iliac spine. For the case, we have the X-ray. You either can put the patient in prone position, lateral position, and discuss it in the approach, but I prefer lateral positioning if you have a wall fracture. So your first step is to relocate the femoral head by applying traction in many ways to retrieve the intra-articular fragments, clean it, and irrigate the fracture area. So you should retrieve the intra-articular fragments. That's another example of intra-articular fragment. And then, after fixation of the column, if it is not, if it is fractured, then you go intra-articularly again to reduce the marginal impaction. So this fragment was here, and we elevate this fragment to be at its right position facing the femoral head. Okay. Then you put some graft, and after putting the graft, you fix this fracture in the deepest level by this missing wire or by mini-set screw. So for the case we had, we reduced the column first. This is the Farabov clamp. I'm sorry, this is the Young-Booth clamp. And when you reduce the column, the femoral head in its place, the articular fragments is repositioned, and then this is the K-wire. Okay? Then you close the shell by variety of techniques. So I said we will not exhaust all the techniques. And then you put intra-fragmentary screw compression of the main fragment. The screws are directed away from the joint. The screws here starts near the joint and are directed away from the joint. And you can judge this if you are doing capsulotomy by stump traction to see if there is any screws here, or by image intensifier, or you can unlock the screw and see from the fracture, unreduce the fracture, and then reduce it and put the screw again. Okay. Then you put your buttress plate. What I was saying in under and over contouring is that in the posterior wall fracture, you need this part of the metal to support and reduce and maintain the reduced position. So you need this part to face the bone as much as you can. So you put the tension on the plate by elevating the periphery of the plate. So when you put the screws, and this screw will go compressing the elevated part of the metal to the bone, it will even compress more the wall fragment, because the metal here is nearer to the bone than in this side and in this side. So this is the way how to put and how to under contour the plate for the wall fragment. But if you have a transverse fracture here, just if you take the AO basic principles of a compression plate, if you put the plate here and did what we said in the wall, this will open the fracture in the anterior wall. What to do? To elevate the central parts of the plate away, a bit away, not very much from the bone. So the periphery will hit the bone before the center. So when you compress, until these screws will go anchoring the bone anteriorly, and here posteriorly, when the plate will come in contact to the bone, the anterior column will close, not open. or the idea of under contouring the central part of the plate in posterior wall fractures. So this should be still not the ideal. We should elevate it here and should be in good contact with the wall in the central part. And here's the X-ray of this case. You see, here is the small fragment, the deepest part of the reconstruction by mini fragment screw. Is the interfragmentary screw for the wall, and here is the buttress screws for the wall and the column. The medial part is for the column and lateral part is for the wall. So in this case, two-level reconstruction for large interarticular fragments, you should elevate the marginal induction using the femoral as template and underbend the plate to reduce the main cortical fragment. And you may use two plates, especially in column and wall fractures or in large wall fragments. Let's take the second case. So are you ready to see the second case? Do you want me to continue?
تمام حضرتك.
ماشي. Okay. We have another example, so we'll apply the principles again in a more complex example. In this example, should we classify the fracture? What is this fracture type? What is the first step to do in this case? What is the first step to do in this case? Please answer it. What is the first step to do in this case? We need some answers here. Any idea? What is the first step to do in this case?
دكاترة احنا ممكن نجاوب في الquestion and answer.
Yes, please. Urgent reduction. Reduce, yes, it is reduction rather than classification, okay? So reduce it first and then send for the CT scan. Fantastic, okay? Very, very, very good indeed. Very good indeed. So the first is to reduce it. So we reduce the fracture, the posterior dislocation, and then we had this fracture, which is a T-shaped because both lines are fractured and the obturator ring is fractured and there is no fracture above the acetabulum in the ilium. So the dome, or at least the part of the dome, the lateral part, lateral to the femoral head, is attached to the sacroiliac joint. So we don't have an anterior column fracture above. So this is T-shaped, not both columns, not anterior column, posterior hemi-transverse. As much as you can, you should not see this X-ray. So even after reducing the dislocation, you should put some traction to avoid injury to the femoral head. Again, this patient had another pathology, which is the opening of the contralateral sacroiliac joint. Seems to be lateral compression type 3 injury because this is the site of trauma and this is the site of the opening of the sacroiliac joint. What to do to identify the pathology? So here is the planning. It's more or less difficult because you have an anterior column and you have a posterior column fracture. This is the posterior column, this is the anterior column. We have in transtectal fracture. I don't know whether there's some induction or not. And a very small posterior wall and an opening of the sacroiliac joint. Again, these are the steps. The femoral head first, then use the femoral head as a template, the column before the wall, the higher before the lower. Use the screws for absolute stability, starting inside the joint and then outside the joint, and then put the buttress plate. In the transverse fracture, what's tricky is the rotation again, and the transverse fracture is rotating or T-shaped or transverse posterior wall, all the same family, is rotated in two planes. One of them is simply flexion extension. So you see, like this is the joint, the fracture is the joint, and this is the torso, and this is the leg. So it is either flexed or extended. Most of the cases it is flexed. And here it comes why in prone position I always make sure that the hip joint is fully extended, so the position will reduce the fracture. But if you put a very large supports here, very large supports here, and the knees are on the table, this will put the posterior column in flexion, and it's very difficult to reduce it in this direction. So the first tip is to position the patient well. Second, it's that it's very easy to see the reduction in the retroacetabulum surface posteriorly in this way, flexion and extension. But you can't tell about the opening of the fracture through all the distance through the journey, especially if the fracture is traveling high in the dome of the acetabulum and exit above the area that you can put your finger and feel it well, that the fracture is reduced. And remember that it is only millimeters. So it's very important not to use your eyes only and not to depend on the adduction clamp here that's closing the only posterior part of the fracture, but you should derotate all this fragment using channel screw, collinear clamp, whatever, okay? The second tricky part is the internal external rotation. And don't bother yourself whether it's internally or externally rotated. Usually, we start putting the channel screw here, putting vertical, okay? If you put it vertical here, just right, you are going from the lateral side. This is the approach. If you put it vertical like this, okay, and you try to neutralize this derotation, you will end by reducing the fracture, okay? But if you put it transverse and then go vertical, you will unlock the fracture. So it's good to put it in an oblique direction, so you can go either internal or external, and you need to go in either ways, because you need sometimes to unlock the fracture before you reduce the fracture. You need to open the fracture to clean the fracture ends before you close it. So it's very good to put it in an oblique direction. Also in oblique and in the direction of the ischial post. If the fracture line is very long, especially in transverse transtectal fractures, it is very tricky that these fracture teeth ends or serrated ends, that will be deceived that the fracture is reduced in a faulty position. So it's very important to watch the edge of the greater sciatic notch, both from posterior and medial, and also it's very important to watch the edge of the joint. So it is not a bad idea that you open the capsule a bit here and see the articular reduction. Okay. Then, when you reduce the proximal part first, I said also you reduce the proximal part, which is the posterior column in this case. I said also you reduce the column first, but there is many philosophies. In our philosophy, that if you lock the distal part of the fracture first, you fix anterior column by anterior column screw, that will allow you to close the gap anteriorly, and then will allow you to play with the fracture again if there is mild rotation before you put the plate posteriorly. This is one of the most logical options. The second option is to reduce and fix the posterior column by either interfragmental screw. So what's the rule of interfragmental screw here? How to put it from distal to proximal or from proximal to distal? You go against the fracture level. So if the fracture is very high, you go from distal to proximal. If the fracture is low, you go from proximal to distal. Another way is to put what's called a magic screw. So you put it percutaneous fixation by stab wound here and to end in the medial side, holding the ilium to the ischium. But be aware not to go through the fracture site or through the medial wall or through the anterior column. So it's very small corridor here. Okay. Many ideas to absolute stability achievement for the posterior column. Either interfragmental screw, a magic screw, or a plate. If you lock the posterior column first and apply compression while you don't see the anterior column, there are two risks. First, that you will maintain a malpositioned anterior column. Second, that your plate here will hide your final judgment on the reduction of the posterior column. So this philosophy is not principles, but my philosophy is to fix the anterior column first. Again, in this case, we'll choose the prone position. Cochlear approach. In some cases, we may need to extend it through the trochanteric flip osteotomy because the posterior column is high. In this case, the same principles. And here, how to reduce the posterior column. This is a very important tool, the shank screw. Then the final play with the collinear clamp or a hook, or the asymmetric Mayo clamp or the Matta clamp. Okay. Or the Jungbluth. Okay. You should use at least 2 clamps, or 1 shank screw and 1 clamp. So why? Because we said that we have 2 planes of Mayo rotation, so you should control every plane by 1 clamp. And here comes the beauty of putting an interfrag screw, because the screw will then allow you to remove at least 1 clamp, and then will make your life easier. How to put a plate in this custom situation? It's possible, but it is more difficult. It is more difficult. Magic screw is from here to there. So you will make benefit from the hump of the ilium here, of the dome. So if you just start at the line of the gluteus medius, and you direct your screw a bit posteriorly, not anterior to the anterior column, a bit posteriorly, or straight away, you will end in the medial side, catching the posterior column. You will make benefit from this bow or humping, because you are starting at the lower part of the hump, and the screw will travel itself to the posterior column. So don't direct your screw so much anteriorly or so much posteriorly. It is just parallel to the ground, above the joint in this direction, or a bit posteriorly, so you catch the posterior edge of the greater sciatic notch. Here's how to fix the anterior column, and we'll elaborate more in this in the coming lecture of the percutaneous fixation. So it starts above the acetabulum, about 3 to 4 centimeters, in the line joining the top of the greater sciatic notch to the midway between the anterior superior and the anterior inferior. You don't, in iliac spine, don't see this because you are doing posterior approach. So at least you see this, so you can draw an imaginary line by your eye here, and then how to know that you are in this line, how to know that you are not anterior to this line or posterior to this line. You will make benefit from the turning of the curve of the ilium, because the ilium has the posterior part, and then it turns anteriorly to make the concavity of the iliac fossa. So if you are at the edge of this curve by the X-ray, as you will see, you are in the right direction, and you aim to the intramedullary canal of the symphysis pubis. So we start at this line, at the greater sciatic notch level, and it's a bit more anteriorly more than you think. So it is from the top of the greater sciatic notch again, about 4 centimeters from the vertex, which is the highest point in the posterior superior dome of the acetabulum, in the connection or the meeting point between the true posterior wall and the dome. And then you put your screw. So in this case, particular case, you use what's called the oblique views, which is called the obturator outlet view. Obturator outlet view, OO view, and iliac inlet view, which is the II view. This view, you control the direction of the screw in the cephalic and the caudal direction, superior to inferior. And here is the line that I'm telling you about. I was telling you about. If you get this view right, the obturator outlet view, so you will see the iliac fossa just like a teardrop here, which is the greater sciatic notch, and this is the outer edge of the gluteus medius line. So if you see your guide wire here in this view, you may be a bit anteriorly or posterior. So you go until you have catching this edge, okay? And then you go as close as you can to the joint, because this is not a real superior to inferior direction. This is just the width of the anterior wall, just lateral to the pelvic brim. So you need to be as close as lateral, because this is the articular surface. This is the iliopectineal eminence. This is the joint. If you went medially, if you go medially by this one, it's very easy to get out the pelvic brim. You need to be lateral to be continuous with the pelvic brim. Okay? And here in the I view, again, iliac inlet view, the greater sciatic notch, the line here, 4 centimeters, and you aim at this V-shaped, or سبعة بالعربي. So this is the V-shaped here. You do an iliac view, so the posterior column are not in the profile of your image. And this is the iliac view, so this pelvic brim is pure anterior column. So you go by the wire in this V-shaped inside the pubic bone. If you went anteriorly, so this is endangering your vessels. If you go medial and I'm sorry, if you go anterior and lateral, you are endangering your vessels. If you go medial, you are endangering your urinary bladder. Okay. So this is to control the cephalic caudal direction, and this is to control the mediolateral direction. The mediolateral direction. طيب احنا هنقول تاني المسمار ده بالعربي.
معلش يا دكتور عبد الله، ممكن كل فيو بيظبط لي ميديال لاترال او انتيريور بوستيريور ازاي بالعربي بس؟
دلوقتي انا وانا داخل المسمار ده عامل زاويه مع الاليم، تخيل انا حاطه عامل زاويه مع الاليم، فانا ايدي دي لو راحت فوق كده يبقى المسمار ده ينزل فين؟ تحت. يبقى ده بيعمل ايه؟ كفالك كودال، صح؟ يعني ارفع ايدي فوق كده اهو هينزل ده ايه؟ كودال. اما نازل ايدي تحت هطلع فين؟ كفالك. يبقى الاو او فيو ده is controlling what's called the cephalic coda direction، دوت بيكنترول المسمار طالع فوق ولا نازل تحت. تمام؟ طالع من الوقت تحت. انما هنا بقى في الالياك فيو لو انا ايدي راحت ميديال المسمار هيطلع لاترال، لو ايدي طلعت لاترال المسمار هيطلع ايه؟ هيطلع ميديال. يعني انا دلوقتي لما بحط المسمار ايديال ان انا ايه؟ اجيب لك اهو ده الجايد واير. تمام؟ الجايد واير ده اهو لو ايديا ديت راحت كده ده كده ايه؟ المسمار هيطلع لاترال. لو ايديا جت كده اهو المسمار هيطلع ميديال. في نفس الوقت لو ايديا راحت ناحيه الاليم في الاتجاه ده اللي هو the other way around in this plane، يبقى كده ده هيروح ايه؟ المسمار لما ايدي يطلع فوق المسمار هينزل تحت، يبقى كفال ايه؟ كودال. لما ايدي تنزل تحت المسمار يطلع فوق، يبقى ده ايه؟ كفالك. So it's in two direction, in two planes. One plane is the coronal plane and the other is the sagittal plane. فده الاوبتريتور فيو controlling sagittal plane. So or oblique sagittal plane. And if you go with this guide wire cephalic, the screw will go caudal. If you go with this guide wire caudal towards the patient leg, the screw will go cephalic. In the coronal direction or mid-coronal plane, if you go with this guide wire medial, the screw will go lateral. If you go with this guide wire lateral, the screw will go medial. واضح يا عاطف؟
واضح يا حبيبي، واضح.
تمام. وبعدين تاخد بالك ان المسمار ده is ايه traversing anteriorly very near to the vessels. What do you think about this screw? Short screw, not in the medulla, not intramedullary. Here it is ending here. Very short screw. Yes. Is it safe screw? What do you think? Is this screw safe or not? You are intramedullary. We stopped at the cortex and we didn't go inside the pelvis because we didn't catch the anterior column proper. About this could be one of the what's called supraacetabular screws, okay, or something like that. What do you think? Is this screw safe or not? This screw is not safe. You see, this screw here ends in the femoral artery. In the femoral artery, and this patient was saved because there is anomaly here called the sciatic artery. Okay, that keep the vascularity of the lower limb, and it was revised by vascular surgeon. So you should be very aware about this screw. It's very dangerous technique. Could be very dangerous. Then when you put the anterior screw, you fix the posterior column, and then because the posterior wall here, another example of the fixation of the posterior wall is not simple. You put what's called spring plate that we talked about. So you take 1/3 tubular plate, you cut it in one of its holes, and then you bend the ends to be like sharp like a spike, and then you put the screw hole in the cortical part, retroacetabular, and allow that spike to dig inside the bone just at the edge of the labrum. Just at the edge of the labrum. مفهوم؟ كلام مفهوم لغايه دلوقتي يا شباب؟
تمام يا باشا، مفهوم.
And then you put your buttress plates, okay, as we told before. Then you put your buttress plates. So in this case, we have many devices for fixation. The anterior column screw or anterior column, the spring plates for the posterior wall, small fragments, the posterior column plate, okay, and here is the posterior column interfragmentary screw, you see it, and the other side you have the iliosacral screw of Dr. Muhammad al-Faramawi, one of the pioneers in pelvic acetabular surgery, right, Muhammad? And in spinopelvic surgery. So this is a long-term follow-up of the same patient of a transtectal fracture, T-shaped, one of the most bad prognosis, and it ends, alhamdulillah, in a good outcome. You have only some flakes of vitinotopic bone formation. To go through the anterior cases, we have only 5 minutes left, and then we will receive some questions. Here we have both colons fractured. It's very evident because both colons are fractured, and we have a fracture of the ilium above the acetabulum, and we have the spare sign. Here is the spare sign. If you plan this, proximal is the anterior column. So you start the proximally here. You start fixing the anterior column first, and then you reduce the lower part of the anterior column, or you reduce the posterior column to the static buttress before you put the pelvic brim plate. Here is the dilemma of the posterior approach versus the ilioinguinal approach. In the classic teaching, you start proximal to distal, as Letournel said. You fix the proximal, and then you reduce the periarticular part of the column, put the screws here, and then continue your journey until you put the lower part of the anterior column in its place. I told you that you put first screw here, then you don't tighten it, and then you go proximally and reduce this. This is the classic way, and then you reduce the posterior column to the whole construct. If it is not reduced, you put the patient on his belly and put another plate from the posterior approach. In the Stopa approach, which is a tricky part, that you can start your reduction here. So you will use, and you will see it in the AO reference, you will use the plate as a reduction and fixation tool. So the plate will effectively reduce this periarticular part of the column and put it in place, because you have more control and more direct vision in this part through the Stopa approach. And then when you reduce it, you can fix this by percutaneous screw only. But in most of the cases, you combine the lateral window of the ilioinguinal approach to control the proximal part of the fracture and the Stopa approach. And the sequence of reduction, as we said, proximal, the head first, reposition the head, proximal column, then distal column, then intra-articular. If you need here intra-articular, you should have another approach, because all anterior approaches are extra-articular approaches. Here is some ways to reduce the anterior column. And in this case, we used the same principles, and then we fix the anterior column here by interfragmentary anterior column screw, by an LC2 type 2 screw going through the anterior inferior iliac spine to the posterior superior iliac spine. And then this is the buttress plate of the anterior column. And we have an infrapectineal plate for the medial side of the posterior column. So every device is making its function in the sequence of reduction. The last case the ilioischial line is intact, or you have just undisplaced fracture here. So it is a pure anterior or anterior column posterior hemi-transverse. Okay. Here is the 3D CT, comminuted anterior column, and you have a small transitional fracture which does not complete the journey to the posterior edge of the posterior column, so it is at least incomplete hemi-transverse. Same principles, we reduce and fix the proximal part of the anterior column. Here we are reducing this key fragment, because this key fragment, although it is cortical fragment, it could be not important itself, as we said, but it is important to judge the rotation. So we fix this fragment by this screw, and then we put the long screw, and we managed to put one of the interfrag screws called Letournel screws or medial wall screw for the fixation of the medial wall fragment. So my take-home message will be that reduction of the femoral head should be before reduction of the fracture. Rotation, rotation, rotation. Screws are very important but very dangerous. Reduction, usually classic from proximal to distal, but fixation could start your first screw distal to control the position of the plates in your more critical proximal location, because distal is usually for anchoring only. Please don't struggle with the fracture. Use as much as tips, as much as instruments as you could, and be careful from your assistant, because he may deceive you in not maintaining the femoral head in place, or may deceive you in putting much force on the retractors, and this may endanger or injure very important structure like the external iliac vein in the anterior approach or the sciatic nerve in the posterior approach. Thank you. If you need any very critical, how to judge the reduction of the vertical components in T-shaped fracture, Mohammed al-Faramawi. Mohammed, we have two types of T-shaped, either wide separation of the vertical component or without wide separation of the vertical component. If there is no wide separation of the vertical component, you can treat it as transverse, or you will not have much struggle in judging the reduction by tactile element that you feel the vertical component in the medial side by your finger if you are doing posterior approach. The second example of T-shape, if the vertical component is really very posterior, so the posterior exit of the vertical component is in the ischium. So in this, you should have more exposure distally until you reach the origin of the hamstring, and to see if you reduced and lock the very distal end of the T-shape. The third is that you have wide separation of the vertical component of the T-shape. First, you should make sure that this is not a low anterior column posterior transverse. And second, you should judge whether you should go posterior first and then go anterior, and this is the case for two approaches. And, if you have time, I can show you one case like this. It's really easy. Okay. What is the best management of a residual subluxed head after posterior dislocation with non-displaced posterior wall fragment, possible labral interposition? If the head is subluxed, this is an absolute indication for open reduction. So dislocation and subluxation are not different in the indication. The head should be perfect under the dome, as we said in the lecture of decision making. Okay. Any other questions? The LC2 type 2 screw put in the same trajectory as external. Yes, perfect. Muhammad Goma, it's almost the same as anterior external fixator, which is the supraacetabular corridor. Okay. Any other question or other suggestions? Again, I'm very sorry for the technical problem in the first half an hour. I hope next time will not be, inshallah, an issue. What can I do if in T shape by the mini good showers? Can I start? I already discussed this, Ahmed. Again, you can, most of the cases, do it from posterior approach. If there is no wide separation of the vertical component or the vertical component is existing posteriorly, but if there is wide separation, you go through double approach. Mostly you go through posterior approach first, and then you fix the anterior column. Or the second option, if the fracture is fresh, you go through the stoppa approach. And you have a very good paper from Switzerland comparing, actually it's a technical paper, not so much number of cases, comparing the outcome of stoppa approach versus surgical hip dislocation in treating T-shaped fracture. Another paper from our center in Alexandria in Injury, published in Injury 2017, about posterior column fixation and anterior column screw in 35 cases of T-shaped acetabular fractures, and we managed all cases like the case you have just said, have just seen, by doing posterior approach and reduction of the anterior column and fixation by anterior column screw. محمد اظن كده كويس. تمام
كده. هو انا بس كنت برضه هرجع انبه تاني ان احنا ان شاء الله كل المحاضرات حاطينها على الشانل، وديت كمان هتترفع خلال اليومين الجايين، وفيديو البلفيك رينج انجري النهارده هيترفع، والستوب ابروتش اللي حضرتك كنت حطيته المحاضره بتاعت الستوب ابروتش موجوده اوريدي.
تمام شكرا جزيلا.
شكرا لك.
نشكر طبعا شركه ليبتس، وان شاء الله باذن الله المره الجايه يبقى الدنيا اسرع واسهل من كده ان شاء الله باذن الله. واحنا يعني متشكرين جدا جدا للدكتور كريم الطويل والمجموعه اللي معاه، كريم الديب اسف، والمجموعه اللي معاه على حسن ضيافتهم لينا دايما. ولو هم حبوا يقولوا اي حاجه، ده هم اصحاب الفرح.
يا دكتور العفو.